is authorized to declare a recess of the committee at any time. We welcome everyone to today's hearing on diagnosing the problem, exploring the effects of consolidation and anti-competitive conduct in healthcare markets. I want to thank our witnesses for being here, and I also want to say that it is our first meeting of this subcommittee, and I particularly want to acknowledge the presence of the ranking member, Jim Sensenbrenner, who I look forward to continuing to work with, who has done a lot of important work in the jurisdiction of this subcommittee, and will bring great wisdom to our collective effort.
If you say so.
Yes, absolutely, without objection. Our healthcare system is in a state of crisis. The cost of prescription medicine has increased by 200% over the past decade. Americans spend roughly $1,200 on average on prescription drugs every year, which is more than people in any other country. The average cost of a hospital stay for a child with cancer is $40,000. The price for many types of organ transplants and post-operation treatment is more than $1 million. Even a short ambulance ride to the hospital without medical care may cost patients thousands of dollars. These outrageous, unsustainable, and immoral costs are ruining lives. Prices are skyrocketing and people are dying or bankrupted as a result. Kaiser Health reports that a quarter of Americans cannot afford their medicine, while many, and I quote, cancer patients are delaying care, cutting their pills in half, or skipping drug treatment entirely, end quote. Despite decades of rising costs, the United States ranks dead last in health outcomes among other high-income countries. And for too many Americans, it is a dark reality that the life of a loved one depends on whether or not they can raise enough money on a crowdfunding platform to pay for treatment before it's too late. Faced with no other options, Americans are left to plead to strangers for help to keep their loved ones alive. This must end. The American people deserve a government that is in their corner, fighting for them to take on drug profiteering and other barriers to affordable health care. Ending this moral crisis is a top priority of mine as chairman of the Antitrust Subcommittee, and a top priority for House Democrats to keep our promise to work for the people and to make health care affordable for everyone. Our competition system is the backbone of promoting open and fair markets. This competition is absolutely essential in the healthcare markets. For drug prices, the entry of generic drug competitors can reduce the cost of branded drugs significantly. In hospital and health insurance markets, consolidation threatens the quality and affordability of care. But in too many cases, effective antitrust enforcement takes far too long to deliver meaningful results to people in need. For example, some branded drug companies have abused safety protocols to thwart generics and to preserve their monopoly power for more than a decade. As Professor Robin Feldman has noted, even months of delay could be worth hundreds of millions of dollars in additional monopoly revenues as the generic sits on the sideline. While this anti-competitive conduct should violate the antitrust laws, even successful cases are often too time-consuming to provide effective relief, as the Federal Trade Commission testified before the subcommittee last Congress. And that's why I've introduced the Creates Act with Chairman Nadler and Ranking Members Sensenbrenner and Collins to end these delay tactics. The Creates Act establishes a tailored path for generic drug manufacturers to bring low-cost drugs to market. The Congressional Budget Office estimates that the bill will result in nearly $4 billion in federal savings, along with an additional $5.4 billion in savings for consumers, according to private estimates. It's also imperative that we examine and address other anti-competitive tactics that lead to higher drug prices. Last week, the FTC settled a complaint against a drug company for paying off its competitor to keep out of the marketplace. According to a 2010 report by the Commission, this type of conduct, also called a pay-for-delay settlement, costs about $3.5 billion per year in the form of higher drug prices. But this settlement occurred nearly 7 years after the Supreme Court's landmark decision in Activist, where it held that these settlements risk significantly anti-competitive effects, and more than 10 years after the FTC originally filed its complaint. It is unacceptable that it took a full decade to address this abuse of our patent system. Moreover, this egregious behavior is still taking place today. As Dr. Aaron Kesselheim of Harvard Medical School noted in his testimony for the subcommittee last Congress, corporations continue to engage in pay-for-delay settlements in the wake of activists' decision, driving up the cost of prescription drugs. I look forward to working with Chairman Nadler and Senators Klobuchar and Grassley on legislation to confront and reverse this problem. In closing, today's hearing is an important opportunity to examine other competitive threats that raise costs, lower quality, and reduce choice in healthcare markets. It is my hope that our discussion today can focus on continuing our work to diagnose the problems associated with consolidation and anti-competitive conduct in healthcare markets, as well as finding solutions to provide a better deal for hardworking Americans on prescription drugs and other healthcare costs. I thank our extraordinarily esteemed members who are witnesses today for appearing before the subcommittee, and it is now my great pleasure to recognize the ranking member of the subcommittee, Mr. Sensenbrenner of Wisconsin.
Thank you, Mr. Chairman, and I thank you and extend a warm welcome to all my colleagues, our witnesses, and the audience members. It's a pleasure to begin the subcommittee's proceedings for this term of Congress, and I look forward to working with Chairman Cicilline to accomplish as much as we can together to meet the needs of the American people. Today's hearing focuses on the issues of vital importance. According to the Centers for Medicare and Medicaid Services, American spending on health care now accounts for 17.8% of the United States' GDP. That's over $3.6 trillion, or over $10,000 per person. These astronomical costs are the result of many factors, lurking always as the misguided Obamacare legislation, sold as a mean to protect patients and make health care affordable, that has produced just the opposite: rising costs, loss of doctors and insurance policies, and increasingly monopolized hospital and insurance markets in states and counties all across the nation. Today's hearing offers us a chance to focus on some of the other important factors in the health care cost problems. These include obstacles to patients' access to low-cost generic drugs, anti-competitive practices engaged by pharmacy benefit managers, and rising consolidation in hospital and insurance markets. To help tackle the first of these problems, Chairman Cicilline and I have introduced in the first weeks of this Congress the Creating and Restoring Equal Access to Equivalent Samples Act, a mouthful, also known as the CREATES Act. Our bill is strong and bipartisan legislation that will deter branded pharmaceutical companies from manipulating test sample availability to block cheaper generic alternatives from obtaining FDA approval and entering the marketplace. The CREATE Act will lead to lower costs for patients by assuring that they have faster access to safe and effective FDA-approved generic drugs. The CBO has estimated that our bill would produce a multi-billion-dollar decrease in the federal deficit. Savings to consumers and private insurers will likely be greater than that amount. I look forward to hearing the witnesses' testimony on the CREATES Act and other important issues the subcommittee will examine today. And I would like a unanimous consent to insert into the record at this point a statement by the National Community Pharmacists Association, statement for the record, and also Pharma's statement to the House of Representatives on the topic of this hearing today.
Without objection.
I yield back.
Thank you to the ranking member. And now it is my pleasure to recognize the chairman of the full committee, the gentleman from New York, Mr. Nadler, for his opening statement.
Thank you, Mr. Chairman. The Judiciary Committee has a strong tradition of bipartisan efforts to promote competition in healthcare markets, particularly with respect to helping to make prescription drugs and other healthcare services more affordable through the full benefits of competition. Over the past several years, the subcommittee has held numerous hearings in this area, examining the topics of consolidation in the market for health insurance, competition in the drug supply chain, and anti-competitive practices by prescription drug companies. It is essential that we continue this important work through today's hearings and throughout this Congress as we seek to provide meaningful relief to Americans who struggle every day with the high costs of medicine, insurance premiums, and hospital bills. Today, 1/4 of Americans report that it is difficult to afford their medicines. 1/4. Exorbitant medical bills is one of the major causes of why Americans seek bankruptcy relief. It is painfully clear that the soaring costs of health care are bad for the health and well-being of American families. It is unacceptable that seniors cannot afford the arthritis medication they need to perform everyday tasks, such as buttoning their coats or opening a jar without excruciating pain. It is unacceptable that hundreds of thousands of cancer patients are reportedly delaying life-saving care, cutting their pills in half, or skipping drug treatment entirely because of high drug prices. And it is unacceptable that those suffering from diabetes have to worry about the life-threatening consequences of not being able to afford insulin because of its unaffordable costs. Last week, when confronted with the facts surrounding skyrocketing prescription drug prices, the executives of 7 major drug manufacturers responded by pointing fingers somewhere else, including insurers and pharmacy benefit managers. But as many experts have noted, including some of the witnesses who will testify here today, the lack of competition in healthcare markets is one of the primary causes of escalating costs. In fact, the CEOs of some major drug companies acknowledge that competition plays a key role in driving down prices. For example, one testified just last week that, quote, competition is a key component to reducing costs, close quote. But frankly, we didn't need him to tell us that. Louis Brandeis told us that a long time ago. The significance of competition from lower-priced generic drugs in particular cannot be overstated. According to the Federal Trade Commission, the first generic competitor's product is typically offered at a price 20 to 30% below the branded product's price. Subsequent generic entry creates greater price competition, with price drops reaching 85% or more off the brand price. Similarly, the Congressional Budget Office reported in 2010 that the retail price of a generic is 75% lower on average, 75%, than the retail price of a brand-name drug. In response to the threat of generic entry, which of course threatens the ability of branded drug companies to charge monopoly prices, these companies, or some of them, have engaged in numerous anti-competitive tactics. This committee has been and will continue to be active in stopping drug companies from reaping monopoly profits at the expense of the health of working American families. For example, I am proud to be an original co-sponsor of H.R. 965, the Creating and Restoring Equal Access to Equivalent Samples Act of 2019, or the CREATES Act. This bipartisan legislation, introduced last month by Subcommittee Chairman Cicilline and Ranking Member Sensenbrenner, seeks to remove an obstacle to generic competition by making it easier for generic drug companies to obtain the samples they need to enter the marketplace. Another concern involves so-called pay-for-delay settlements, which occur when a branded drug firm pays a potential generic competitor to abandon a patent challenge and thereby delay entering the market with a lower-cost generic product. These agreements can be a win for both drug companies. The brand-name drug company gets to keep its monopoly, and the generic gets paid off with a portion of the monopoly profits. But consumers lose. According to an FTC study, pay-for-delay agreements are estimated to cost American consumers $3.5 billion per year, $35 billion over the decade from 2010 to 2020. That is why I plan to introduce bipartisan legislation in this Congress to help end pay-for-delay settlements. As we all know, a lack of competition and anti-competitive conduct is not just limited to the pharmaceutical marketplace. These problems show up in hospital markets as well. For example, it is well documented that hospital mergers can lead to higher prices and lower quality of care. Hospital consolidation also results in fewer options for patients. This is especially harmful for expecting mothers or women seeking reproductive health services who depend on a full range of options for care and may be faced by a regional hospital that doesn't give a full range of options. I hope that our discussion today will continue our bipartisan work to diagnose the problems associated with consolidation and anti-competitive conduct in healthcare markets, as well as break new ground on confronting the harmful effects of hospital consolidation. Accordingly, I look forward to hearing from our witnesses today. I thank them for their participation and yield back the balance of my time.
I thank the gentleman. Now I'm pleased to recognize the ranking member of the full committee, the gentleman from Georgia, Mr. Collins, for his opening statement.
Thank you, Chairman Cicilline and Ranking Member Sensenbrenner, for holding this hearing. I'd also like to thank both of you for the works on the CREATES Act, and I believe this legislation is a good starting point, and I look forward to continuing to work with both of you to ultimately get this bill signed into law this term. Over the past decade, consolidation across healthcare and prescription drug markets have been rapidly increasing. Nowhere is this more prevalent than in the pharmacy benefit manager marketplace. PBMs, in theory, should bring down the cost for consumers. However, they're not doing that. There are only 3 major PBM companies, and they control 85% of the marketplace, which yields each company a great deal of power. And these companies have consolidated horizontally as well as vertically as they go forward, and they have merged vertically with major pharmacies and health insurers. That means patients' insurers has financial incentives to push the patients toward their pharmacies. This consolidation has enabled PBMs to engage in anti-competitive behavior by targeting competing pharmacies with unfair audits and under-reimbursement. These audits provide PBMs with the pharmacy's acquisition cost and patient data. PBMs then use this data to steer patients to their own pharmacies and reimburse competitive pharmacies at a much lower rate. This results in PBMs lining their own wallets. It harms community pharmacists who have to decide between losing money and filling a prescription or losing customers to big box pharmacies owned by PBMs. If you look at Ohio, CVS and Optum Rx charged that state more than $400 million more than they paid out to pharmacies. It is just amazing to me that we will continue to turn an eye and not have the discussion. If we wanted to lower drug costs in this country right now, start with the PBMs. Start right where they're at. I've been talking about this for 6 years. I just laid it out. They're going full throttle trying to kill independent pharmacists and pharmacies in our communities. They offer little more than anecdotal evidences of saving money. In fact, when others have actually, states such as Texas and companies such as Caterpillar and others have actually went away from their PBM system, they saved money. PBMs, it's just amazing, have immense control over patient formularies, allowing them to push patients to high-cost medications because these medications give the PBM higher rebates. As a result, PBMs increase patient copays and incentivize manufacturers to increase drug costs to pay PBMs higher rebate demands, so PBMs are actually costing patients money. PBM's role as intermediaries also allows them to extract rebates and price concessions for competing pharmacies and manufacturers without passing them on to the patients. You know what's really interesting about this? I've been talking about this 6 years. I've never had a PBM come in and deny what I say. Never. They just don't like the way I talk about them. They don't care that their practices are bad. They just don't like that I call them for it. It's amazing. This lack of transparency in the price concessions are often withheld from patients and payers and increasing PBM profits while failing to decrease drug costs. I recently introduced a legislation called the Fair Pricing Act with Representative Gonzalez from Texas, Democrat from Texas, and also Senator John Kennedy from Louisiana. This legislation will require PBMs to pass pharmacy rebates and price concessions on to patients at the point of sale. That will save patients an estimated $9.2 billion over the next 10 years. Key provisions from my legislation are also included in the proposed rule from the Department of Health and Human Services Secretary Alex Azar. Additionally, states across the country, including my home state of Georgia, have realized this lack of transparency in the marketplace, and legislators are passing laws requiring transparency for PBMs regarding the rebates, price concessions they are receiving from pharmacies and manufacturers. These laws aim to ensure that patients are receiving and seeing the savings PBMs claim to be offering and negotiated on their behalf. I do want to talk, Mr. Chairman, about another issue that is dear, especially in Georgia, and that's hospital consolidation that the full committee chairman also talked about in rural communities. These communities often already have few options for quality care, so a hospital consolidation is increased over the past 10 years. Rural communities like my own have been hurt the most. At times, these mergers and acquisitions can help rural communities by keeping facilities open, but they result in full or partial closures and shifting patients from nearby facilities to those hours away. This doesn't benefit patients. Instead, it hurts them because they're unable to receive the life-saving treatment they need. In some areas of my state, we have seen mergers limit emergency care, increase patient travel time by hours. Imagine if a woman was in difficult labor but had to travel hours to a healthcare facility. These changes can literally mean the difference in life and death. I've also seen hospitals acquire other pharmacy and physician practices in the area to steer patients away from their competitors. I'm concerned that these practices will result in fewer options for patients, higher costs, and a lower quality of care. I want to commend this subcommittee for reviewing the consolidation and anti-competitive practice across the healthcare marketplace. And I'm looking forward to working with the chairman and others on this across the aisle to find real solutions, because we must decrease the cost of our healthcare and prescription drugs while increasing patients' access to the best care possible. And that means taking a look at everything on the table. And it is time the pharmacy benefit managers realize your time of terrorizing this marketplace is over. And with that, I yield back to the chairman.
Thank you, Mr. Collins. It is now my pleasure to introduce today's witnesses. Our first witness on today's panel is Dr. Fiona Scott Morton, the Theodore Nierenberg Professor of Economics at Yale University School of Management. Dr. Scott Martin is nationally recognized as a leading scholar on issues of competition and has published articles that range widely across industries in leading economic journals. From 2011 to 2012, she served as the Deputy Assistant Attorney General for Economics at the Antitrust Division of the U.S. Department of Justice, where she helped enforce the nation's antitrust laws. Dr. Scott Morton received her BA from Yale and her PhD from the Massachusetts Institute of Technology. Welcome. Our next witness is Michael Cadis, the Director of Markets and Competition Policy at the Washington Center for Equitable Growth. Prior to joining Equitable Growth, Mr. Cadis served as antitrust counsel for Senator Amy Klobuchar, and before that as an attorney at the Federal Trade Commission for 20 years. His work on anti-competitive pharmaceutical patent settlements led to the Commission's victory before the Supreme Court in FTC versus Activists. During his time at the Commission, he was also an attorney advisor to Chairman John Leibowitz and the Deputy Trial Counsel. Prior to working at the Commission, Mr. Cadis clerked for the Honorable John Reynolds at the United States District Court for the Eastern District of Wisconsin, and is a graduate of Yale University and the University of Wisconsin Law School. Our third witness is Dr. Martin Gaynor, the E.J. Barone Professor of Economics and Health Policy at Carnegie Mellon University. Dr. Gaynor is widely recognized as a leading scholar on competition, and in particular, the study of consolidation and market power within hospital markets and healthcare systems. Dr. Gaynor previously served as the director of the Federal Trade Commission's Bureau of Economics and as a research fellow at the National Bureau of Economic Research. He received his BA from the University of California, San Diego, and his PhD in economics from Northwestern University. Our final witness at today's hearing is Dr. Craig Garthwaite, the Herman Smith Research Professor in Hospital and Health Service and the Director of the Program on Healthcare at the Kellogg School of Management at Northwestern University. Dr. Garthwaite's research examines the effects of government policies with a focus on health and biopharmaceutical sectors. He's appeared as a guest on various television and radio shows, such as NPR Marketplace, and has appeared in journals like the American Economic Review and Health Affairs. Dr. Garthwaite received his BA and Master's in Public Policy from the University of Michigan and his PhD in Economics from the University of Maryland. So we welcome all of the distinguished witnesses and thank them very much for participating in today's hearing. Now, if you would please rise, I will begin our hearing by administering the oath and swearing you in. Please raise your right hands. Do you swear or affirm on a penalty of perjury that the testimony you are about to give is true and correct to the best of your knowledge, information, and beliefs to help you God? The record should reflect that the witness has answered in the affirmative. You may be seated. Thank you very much. Please note that each of your written statements will be entered into the record in its entirety. Accordingly, I ask that you summarize your testimony in 5 minutes. To help you stay within that time, there's a timing light on your table. When the light switches from green to yellow, you have about a minute to conclude your testimony. When the light turns red, it signals that your 5 minutes has expired, and I would ask you to please conclude, and we'll begin with Dr. Scott Morton. If you would just hit the button so we can talk.
Thank you, Mr. Chairman, and members of the committee for the invitation to testify. Today in the United States, we are choosing to use the private sector to provide health care without establishing enough rules to ensure competition. The result is that we have providers who are profit-seeking and without the restraint imposed by competition. My belief is that if we do not fix this, that the ever-increasing costs are going to lead to a different kind of solution, which is just price regulation by the government. That's not my preferred solution. I think markets would be much better, but they have to be working markets. It's not obvious that price regulation would be worse than unrestrained private monopolies, which is what we are faced with today. As you'll hear from the other members on my table, is that we have good news. High prices in many areas of pharmaceutical and medical care are eminently fixable. It is not rocket science what we're going to tell you. There's a great deal of evidence about how to bring down these prices. The bad news is that the providers, whose prices will come down should they face vigorous competition, are going to lobby against any changes in the law, and historically have been very successful at doing that. For the conservatives in the room, if you claim to like markets and you like market solutions over government, this is what you're going to hear today. I think all of us want markets, but we want working markets, ones that enable competition. I have 2 main points to discuss from my testimony. The first is the area of biologics and physician-administered drugs. This is the area with the most growth currently. These are very high-priced products. They're growing very quickly, both in terms of price and in terms of quantity. We procure these drugs primarily through the Part B program, as well as on the commercial side. This is run quite differently from Part D. Part D, like dog, okay, that's the one where we outsource to private insurance companies who have a formulary and they bargain and get low prices. Part B, like boy, that's the one where we do nothing. We allow the manufacturer to announce a price and then the government pays that. Okay, so it's not really very surprising that it's only 18% of GDP we spend on healthcare. Probably should be more. What's the restraint? Well, the manufacturer does have to sell in the commercial marketplace, and as prices get higher, that gets difficult, but there's no restraint on the government side. So this is something that Congress should fix. We should be procuring Part B drugs in a way that's competitive. One way to do that would be to change the system of J codes. Currently, if there's a branded product that's a biologic and biosimilars enter, each of those manufacturers gets their own reference price, their own J code. So if the brand costs $1,000 and the biosimilar costs $600, a doctor that dispenses the biosimilar gets paid $600 plus a markup, and the one that chooses the brand gets paid $1,000 plus a markup. If we had one payment for all the drugs that are the same, all the same molecule, then the branded drug would have to come down, or else the doctors would all pick the biosimilar because they would be being reimbursed at $600. They would not choose to buy a $1,000 drug. That same principle works in other areas. We, for a brief while, had a least cost alternative in the area of prostate drugs. That caused doctors to go out and actually seek the lowest cost therapy in that class. And the result of that was such good competition that the brands in question sued the government, and over the fact that the government, CMS, did not have the authority to procure drugs in that competitive a manner, and they won. So it would be useful if Congress would enable the government to procure drugs in that cost-effective manner. My second point is about consumer out-of-pocket costs. These have gotten very high with the popularity of high-deductible plans. When you have an out-of-pocket cost that's based on the list price of the drug, this generates kind of negative insurance. You buy insurance, and instead of paying market price for the drug, let's say $300, you pay list price for the drug, $600. So you're getting the opposite of what insurance is supposed to do, which is to smooth these financial shocks when you get sick. The HHS solution, which makes consumers' out-of-pocket costs depend on the net price, I think something like that is a good idea. It could either be the true net price, it could be some well-defined average to make the net price continue to be confidential, which is very important for getting low prices in general, or it could just be below, equal to or below the net price, so that a plan could choose to have a $50 out-of-pocket cost, and we would never know what the net price was, and that would also be fine. The important thing about this solution that HHS has come up with is that it's going to restrain competition between manufacturers. I believe this is why manufacturers are in favor of this rule, because it's not going to intensify price competition, it's going to lessen price competition. Why? Because there won't be able to be performance-based rebates, where a plan says, I will deliver you a high market share from drug A to drug B, and drug B says, okay, if you deliver that high market share, I'm willing to sell to you at a low price. We don't know till the end of the year if the market share gets delivered, and therefore what the price should be. So there needs to be built into whatever the safe harbor is, the ability for the plan to negotiate that way with the manufacturer, extract a really low price, and then, sorry, I'll stop, and then deliver that to the patient. So that's key.
Great. Thank you so much, Doctor. I'll now recognize Mr. Cadis for 5 minutes.
Thank you, Chairman Cicilline and Ranking Members Sensenbrenner and full committee. Oh, Mr. Nadler stepped out. So I just want to start with Ranking Member Sensenbrenner, just for the record.
Mr. Cadis, would you just pull your microphone closer to you so folks can hear it? Yeah.
Yeah, so Ranking Member Sensenbrenner, I just want to state for the record, I was born and raised in Beloit, Wisconsin, fairly close to your 5th district. And when you've said Wisconsin, you've said it all. It is an honor to testify before this subcommittee on competition and prescription drug prices. This issue is vital to the healthcare system and affects all Americans. I am Michael Cadis, the Director of Market and Competition Policy at the Washington Center for Equitable Growth. We seek to advance evidence-based ideas and policies that promote strong, stable, and broad-based economic growth. The exploitation of monopoly power is the kind of inequality that is at the core of the most important challenges that our economy and nation face. Prescription drug costs are and will continue to be a burden. In 2017, the United States spent $333 billion on prescription drugs. That's over $2,600 per family. 3 out of 10 Americans are not taking prescriptions as directed because of costs. So this isn't just about money, it's about people's health and well-being. No silver bullet exists to ensuring prescription medicine is affordable. It requires a broad range of policies, but increased competition should be part of the answer. Stopping anti-competitive conduct will both lower prices and promote innovation. For 20 years at the Federal Trade Commission, I was on the front lines of what has been and continues to be a never-ending struggle to protect competition in pharmaceutical markets. I litigated and investigated dozens of pharmaceutical antitrust matters, and I'm here to tell you the system is broken. The incentives for anti-competitive activity in these markets is substantial. For example, delaying competition on a blockbuster drug for just a year can mean hundreds of millions, if not billions of dollars in additional profit. The antitrust laws should stand as a bulwark against anti-competitive conduct. Unfortunately, courts have stripped those laws of their potency, narrowing the scope of the law and imposing ever higher burdens of proof. Easy cases have become hard, and hard cases escape condemnation. Companies have been emboldened to push the limits of business conduct because the rewards are great and the risks are minimal. Even if they get caught, the penalties are low. The result, consumers pay hundreds, if not thousands of dollars more each month for their prescriptions. I want to focus on 3 practical policies that would help focus competition in the pharmaceutical markets, which this committee can work on this year. First, pass the Creates Act. Chairman and Ranking Member Cicilline, Sensenbrenner, Nadler, and Collins, this bill, this obviously bipartisan, but which is also a bicameral supported bill, would stop one of the most egregious strategies that limits competition. Sometimes it's hard to explain. I like to put it down into one simple phrase. No samples, no competition. Break that chain and you will save billions of dollars for the government and American citizens. Second, pass legislation to stop branded companies paying generic companies not to compete in the marketplace, what is called a pay-for-delay patent settlement. Despite the Supreme Court's clear signal that these deals can be anti-competitive, the FTC still expends substantial resources challenging clear antitrust violations. Chairman Cicilline, you referred to the activist case which just got settled. When that case was filed, my daughter was learning how to read. She's coming home from her spring break of first year of college. That's how long it took to get a resolution of that case. That's too long. Enacting a law with clear standards, such as the Preserve Access to Affordable Generics Act, would deter this practice and free up limited resources to attack other anti-competitive conduct. Third, make bad actors pay a real penalty. The key to deterring anti-competitive conduct is that when somebody violates the law, they shouldn't benefit from it. In the world of antitrust lawyers, we call this disgorgement. You make them give up their profits. But even in this area, the Federal Third Circuit Court of Appeals just last week, ignoring 35 years of precedent, clipped the ability of the FTC to obtain this type of relief. This Congress should modify the Federal Trade Commission Act to clarify explicitly that the FTC can obtain this type of relief. It's critical to deterring highly profitable, but anti-competitive conduct. Thank you, and I look forward to listening to your questions.
Thank you, Mr. Cadis, and I recognize Dr. Gaynor for 5 minutes.
Thank you. Chairman Cicilline, Ranking Member Sensenbrenner, and members of the subcommittee. Thank you for holding a hearing on this vitally important topic and for giving me the opportunity to testify in front of you today. The focus of my testimony is on healthcare, hospitals, doctors, insurers, which collectively account for almost 60% of all of U.S. healthcare spending. Over the next few minutes, I'll briefly summarize for the committee the basic facts about healthcare markets, the considerable research evidence on competition in healthcare, and my views on steps that can be taken to help make these markets work for the benefit of consumers. Healthcare is a very large and important sector of our economy. Not only is it almost 1/5 of the entire economy, it has a critical impact on our health and well-being. Our healthcare system is based on markets. That system is only going to work as well as the markets that underpin it. Unfortunately, these markets do not function as well as they could or should. Prices are high and rising, there are egregious pricing practices, quality is suboptimal, and the sector is sluggish and unresponsive, in contrast to the innovation and dynamism that characterize much of the rest of our economy. Lack of competition has a lot to do with these problems. There has been a great deal of consolidation in healthcare. There have been nearly 1,600 hospital mergers in the past 20 years. The result is the majority of local areas are now dominated by one large, powerful healthcare system, such as Pittsburgh, my home, by University of Pittsburgh Medical Center, Boston by Partners, San Francisco Bay Area by Sutter. The same is true of health insurance markets. The two largest insurers have 70% of the market and over 1/2 of all local insurance markets. Physician services markets have also become increasingly more concentrated. 2/3 of specialist physician markets are concentrated, and 29% for primary care physicians. Moreover, there were nearly 31,000 physician practice acquisitions by hospitals from 2008 to 2012, and about at least a third, of all doctors are now in hospital-owned practices. This massive consolidation in healthcare has not delivered for Americans. It has not given us better care or enhanced efficiency. On the contrary, extensive research evidence shows us that consolidation between close competitors results in higher prices, and patient quality of care suffers from lack of competition. Moreover, competition affects the form of payment. Hospitals with fewer competitors negotiate more favorable forms of payment and reject those they dislike. This poses a serious challenge for payment reform. Hospital mergers can also harm competition in labor markets. They can depress wages, distort hiring decisions, and harm incentives for investment in human capital. Recent evidence shows impacts of hospital mergers consistent with these concerns. There are also concerns about anti-competitive conduct. Firms who've acquired market power want to keep it. Some dominant health systems have been using restrictive contracts with insurers to try and hamper the free flow of patients to competitors, thereby harming competition and enhancing their market power. There are extensive reports of health systems engaging in data blocking, impeding the flow of patient information to providers outside the system. This has the potential to harm competition by making it more difficult for patients to switch providers. Now that most hospital markets are dominated by one large health system, there is considerable potential for this kind of conduct seriously harming competition. All of this is causing serious harm to patients and to the healthcare system as a whole. Policies are needed to support and promote competition in healthcare markets. These include ending policies that unintentionally incentivize consolidation, ending policies that impede new competitors and impede competition, focusing and strengthening antitrust enforcement, in particular, giving the DOJ and FTC resources so that not only can they do more enforcement in existing areas, but can proactively invest to address new and developing issues. Permit the FTC to enforce against anti-competitive conduct by not-for-profits. Permit the FTC to use its Section 6B authority to study the insurance industry. Require simple reporting of small transactions that fall below the Hart-Scott-Rodino reporting requirements, so the enforcement agencies can track physician practice mergers, they currently can't, and hospital acquisitions of physician practices. Study vertical aspects of hospital physician acquisitions and develop theory and evidence on competitive impacts. Study anti-competitive conduct and develop theories and evidence. And last, consider legislation to alter the antitrust law, specifically changing the standard plaintiffs have to meet and changing criteria to be met for presumption of harm to competition. Thank you very much.
Thank you, Dr. Gaynor. I now recognize Dr. Garthwaite for 5 minutes.
Thank you, Chairman Cicilline, Ranking Member Sensenbrenner, and members of the committee for holding a hearing examining the role of competition in healthcare. I'm here today to talk about why markets can work in healthcare, with a particular focus on the pharmaceutical sector. I've prepared a longer written statement outlining more specific details that I've submitted to the committee. Unlike most other developed countries, the United States primarily relies on lightly regulated private markets for the provision of healthcare services. This choice makes sense because private firms respond to market incentives and create products and services that maximize welfare, either by lowering costs or by increasing quality. In this way, the profit-seeking motives of private firms benefit society in ways that even the most benevolent government entities cannot. Optimal healthcare policy then harnesses these market forces while maintaining no illusions about the motivations of the firms we employ to efficiently provide these goods and services. However, relying on the private market for the provision of such a vital set of goods and services requires recognizing two key facts. First, healthcare markets, like any other markets, can fail. And second, all markets require vigilant protection of the structures and institutions that support robust and vigorous competition. Complicating matters is the uniquely public-private nature of the U.S. healthcare system, where even government-financed social insurance and medical services are increasingly the domain of private firms reacting to these market incentives. While I think the benefit of the markets are clear, I fear there are a number of areas where a combination of both market structure and poorly developed regulations limit the ability of the market to deliver its most efficient outcome. There are many areas of healthcare where this is true, which other witnesses have already testified to. Today, I'll concentrate my remarks on pharmaceutical markets, a sector that generates meaningful value, but all too often attracts the ire of policymakers and the general public. It's not surprising that such negative attention is focused on the pharmaceutical sector. Certainly some of this is the result of bad actors by some industry participants, but poor behavior is hardly unique to this sector. Far more is about the simple fact that the products are sold for many multiples of marginal cost. However, claims that these prices solely represent corporate greed ignore the vital societal trade-off where we accept limited access to drugs from high prices today in order to provide incentives for the development of new and innovative products in the future. That said, our goal is not to give firms unlimited profits, but instead to provide a time-limited period of increased market power in order to encourage innovative firms to make the necessary investments. During this time period of exclusivity, we want to ensure that firms offering therapeutic substitutes still compete for patients, and therefore the greatest profits go to the firms that have the most uniquely valuable products. Following exclusivity, welfare is then maximized by a robust and competitive generic market. Today, I'll briefly highlight some specific proposals I believe sensibly address these concerns. The first set of proposals are for generic markets. First, as Mr. Cadis said, Congress should immediately pass the Creates Act in order to facilitate the availability of necessary product samples for potential generic entrants. Second, Congress should authorize regulators to investigate the abuse of citizens' petitions, which artificially delay the entry of generic competitors. Third, Congress should create a new form of generic exclusivity targeting molecules with small patient populations. Markets that are too small to attract multiple competitors allow incumbent firms to set prices as natural monopolists. This was most apparent in the case of Martin Shkreli and Turing Pharmaceuticals, but this practice is now widespread across many firms. The FDA should create an RFP process where firms can apply to be the sole supplier of these small markets at a fixed margin over production cost. The next proposals are for the branded market, where policy should facilitate robust competition between therapeutic substitutes. This competition currently takes the forms of rebates negotiated by pharmacy benefit managers, or PBMs. While confidential rebates have become a much maligned part of the system, they're actually a vital component that results in large discounts. When rebates are confidential, firms are more willing to give large discounts in the first place and less able to tacitly collude on high prices. That said, there are some improvements that can be made to the rebate system, and I'd highlight two particular suggestions. First, we must provide a means of passing along the rebates to consumers at the point of sale, a way that supports competition and confidentiality while restoring the insurance benefit to these sick patients. This can be accomplished by basing cost sharing not on the list price of the drug, but on some other discounted price, such as the average price across payers for the molecule. Second, we must provide the structure to ensure that PBMs act as good agents for their payers. Currently, many policymakers are worried this is not occurring. In particular, they're worried that PBMs are capturing an inappropriately large amount of the discounts that are provided by the manufacturers. In order to improve competition, I propose, along with Dr. Scott Morton, that we increase the amount of information payers have about the money flowing between PBMs and manufacturers. For example, Congress could ban payments directly between PBMs and manufacturers and require all discounts and fees be paid first to the final payer. Payers and PBMs can then negotiate about efficient distribution of that surplus. While I understand the temptation to abandon markets in the favor of a greater use of government purchasing power and regulated prices, such policies are short-sighted, and they ultimately throw the baby out with the bathwater. Thank you.
Thank you, Doctor. Thank you to all of our witnesses for your opening statements. We will now proceed under the 5-minute rule with questions, and I'll begin by recognizing the gentleman from Georgia, Mr. Johnson.
Thank you, Mr. Chairman, and thank the witnesses for your appearance today. Drug prices are rising every day, and the burden is being felt most acutely at the lowest level, the consumer. Yes, this problem is complex and unwieldy, and with a variety of competing interests. And it seems that these competing interests threaten any incentive to keep costs down. Lack of competition in the market is driving prices up, and everyday Americans are paying a higher and higher amount for life-saving medications. Mrs. Morton, do you believe that the American government is utilizing our antitrust protections in the drug pricing chain properly?
No.
Why do you think antitrust enforcement has weakened?
The answer to that is probably longer than we have time today. But Mr. Cadis's remarks about the Creates Act, about defending pay for delay, citizens' petitions, blocking of biosimilar entry in various ways, all of these are potentially anti-competitive behavior that the FTC could go after, but the FTC is limited by the court's negative views of antitrust enforcement, the limits of the FTC on nonprofits, and other areas that are highlighted in his testimony. I think Congress could fix many of those things.
So more laws and more regulations would be the fix?
I think more laws making it clear what the antitrust law is supposed to capture and giving the FTC authority to go after those cases.
No, it wasn't the Affordable Care Act passage that caused this dilemma, is it?
No.
And in fact, the tens of millions of people who were brought into the healthcare system upon passage of the Affordable Care Act, that is not the cause of consolidation in the insurance and the hospital industries and in terms of the high cost of prescription drugs. Is that correct?
To the best of my knowledge, that is correct.
Well, let me ask you this question about prescription drugs. Federal law prohibits itself from negotiating with drug manufacturers over the cost of prescription drugs for Medicare Part D enrollees. Would removing this handcuff result in lower costs for Medicare Part D employees and the Medicare program?
Medicare Part D is run as an outsourced, privatized program where insurance companies negotiate with drug manufacturers. So they do pretty well. They have a formulary. They can walk away. I think it's very difficult for the Secretary of Health and Human Services to walk away from a drug manufacturer and say, I'm sorry, drug A will not be available to anybody, any of America's seniors. That's a hard thing to say. It's not very credible. Whereas an individual insurance company can say, well, we're going to put drug A low, on a high tier with a high copay, and drug B is going to be our preferred drug. So I think Part D works pretty well. It's Part B that's really not good.
You think the handcuffs on Part B should be removed?
Correct.
And that would lower cost for the 15% of consumers enrolled in that program?
Well, we all pay the taxes for it.
Well, you're right about that. Well, let me ask you this question also. With respect to consolidation in the health insurance industry, would passage of legislation that allowed for what's known as the public option, passage of that legislation, would it result in a competition that would lower prices for consumers?
The public option has a lot of different definitions, but certainly anything we can do to make the Affordable Care Act marketplaces more competitive with more choices for consumers, that would be a great help, and it would lead to lower prices.
Thank you. So the constant attempts to destroy the Affordable Care Act, which enabled tens of millions of people to have access to this system, don't do anything to cut the consolidation in the hospital and insurance industries or the rise in prescription drug prices. Do you all agree with that? Yes, 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 and yes?
Yes.
Okay, well, let the record show everybody agrees with that. And with that, I will yield back.
Thank you, Mr. Johnson. The chair now recognizes the gentleman from Wisconsin, Mr. Sensenbrenner, for 5 minutes.
Thank you, Mr. Chairman. I have some questions for Dr. Gaynor. First, you note in your written testimony that Americans who live in rural areas are vulnerable to harms from hospital consolidation and anti-competitive behavior. My home state of Wisconsin has been particularly affected by rural hospital mergers, with 19 mergers taking place between 2005 and 2016. Why does this happen more in rural areas than in urban areas?
Thanks for your question, Member Sensenbrenner. I don't know that I can answer why it's happening more frequently in rural than urban areas at this point in time, but I'm happy to consider it further and submit an answer in written testimony. Nonetheless, there are quite a few mergers that are happening across the board, not just in rural areas. And there are lots of things that are driving those mergers. As we all know, there's a merger wave in the U.S. economy happening that is affecting what's happening in healthcare. There are motives on the part of merging parties to enhance their negotiating positions by merging and eliminating or harming competition. There's sometimes a game of musical chairs that happens where they see everybody else merging and they don't want to be the last one left standing when the music stops. Nonetheless, Americans who live in rural areas are particularly vulnerable because if there's only one provider or a dominant provider, it's very difficult for them to go elsewhere. And so they can be particularly harmed by the mergers that enhance or create market power in the areas that they live.
Okay, second question. In your written testimony, you explained that some states have regulations that unintentionally make it difficult for new care providers to enter the market, and that the negative impacts of these laws can particularly affect residents of rural areas. Can you tell me what kind of state regulations or laws make it difficult for new hospitals or other providers to offer healthcare services? And again, why does this happen more often in rural areas than in urban areas?
Thanks again for your question, Ranking Member Sensenbrenner. So there are a number of examples of this. There are a set of laws called Certificate of Need laws. About 26 states in the Union still have Certificate of Need laws.
We had them in Wisconsin and repealed them.
Yes. Pennsylvania, for example, had such a law at sunset about 95 or 96, but about half of all states still have them. And that requires review and approval by a regulatory commission to create a new facility or expand a new facility, whether it's a hospital, an ambulatory surgery center, that sort of thing. Another area that's particularly important has to do with the decisions of state licensing boards about what sorts of entities are allowed to practice and provide health care. Telehealth is one example of that, where state licensing boards have discretion over the provision of telehealth. The scope of practice for nurses is another area. What nurses are allowed to do and not do, what sort of supervision is required. And last but not least, independent pharmacists are also subject to these regulations. Now, the regulations are statewide, but why might they affect folks in rural areas particularly more? Well, telehealth is easy to see. If you live in an area where there are not a lot of providers physically, the ability to obtain care through telehealth for some kinds of services can greatly expand the opportunities for care. If nurses can do more, if pharmacists are allowed to do more, that expands the supply of healthcare professionals, and so creates more opportunities, more care, and more competition in those areas.
Thank you very much. I yield back.
Thank you, Mr. Sensenbrenner. The chair now recognizes the distinguished gentlelady from Washington State, Ms. Jayapal, for 5 minutes.
Thank you, Mr. Chairman, and thank you so much for having this hearing. Thank you all for your testimony today. I think it's important that we remind people that might be watching what we're talking about, which undergirds everything you've said, which is that today in the United States, we spend about 18% of our GDP on healthcare, which is double what every other major industrialized country, almost double what every other major industrialized country in the world spends on healthcare. And you might think, if you were listening to this, that that means we have great outcomes. But in fact, the United States is worst of our peer countries on maternal mortality. That's moms that die in childbirth. We are worst in terms of infant mortality. That's kids that die when they're young. And we are worst in terms of life expectancy. We have the lowest life expectancy. And so this is a marketplace that truly is broken. And I think you all have raised important considerations. I wanted to point out that this is also a marketplace where the top 5 private health insurance companies bring in annual profit of $90 billion a year. The top pharmaceutical companies bring in $75 billion a year. And this is as people are dying because they can't afford insulin or cancer treatments. And so I have introduced our Medicare for All bill here in the House and have 106 distinguished original co-sponsors. And so I wanted to just turn, Professor Gaynor, to you first. You are an expert on competition and antitrust policy, and particularly in the healthcare markets, as was evident from your testimony. And you stated that the U.S. healthcare system is functioning at a subpar level, which has resulted in this egregious pricing that we see and the poor quality of care. And you attribute that largely due to the lack of competition caused by a highly consolidated healthcare market. So can you just explain in the simplest terms why this consolidation is occurring? Why are all these firms merging, and what's driving that?
Representative Jayapal, thank you for your question. There are multiple reasons. So one reason that consolidation occurs is very simple. The consolidating firms want to enhance their negotiating power, get higher prices, and have higher profits. And sometimes the executives of these firms actually admit that in public. That's rather rare. Usually the lawyers are none too pleased. But for example, Toby Cosgrove, very, very accomplished CEO, former CEO of the Cleveland Clinic, was interviewed by the Wall Street Journal in 2012 and said as much. That's exactly why we do those things. So that is one reason, and though there are others, I think that's important. Another reason has to do with sort of not a virtuous, but a vicious cycle in which consolidation can happen on one side of the market, and then the providers or the insurers on the other side feel that their negotiating position has been harmed, so they consolidate in order to try and shore that up, and this can go back and forth in a vicious cycle. As I said previously, there can also be musical chairs.
I'm so sorry. I want to ask you a couple other questions, and I'm going to run out of time.
Yeah, we could go on for some time.
But really important, I just want to emphasize, so merging is happening because when you merge, you have greater negotiating power, which means you can drive up prices and profit, really simply. So do you believe that the goal of the healthcare system should be to serve patients and improve health and not to increase profits?
It's absolutely.
Okay, great. And is this increasing concentration in our healthcare markets targeted at improving patient outcomes, at that primary goal of getting better patient outcomes, better healthcare, and making care more affordable?
No.
So who is paying for the rapidly increasing prices that we are seeing from these hospital and healthcare consolidations? Is it just patients? Who's paying for that?
Ultimately, actually, it's all of us. When we have prices go up in healthcare, we don't see it directly in the same way if, say, there's a merger of grocery stores or paper suppliers or that kind of thing. But nonetheless, it comes back to all of our wallets. For example, just simple statistics, over the past 20 years, worker contributions to health insurance have risen by 239%. Over that period, wages rose by 68%. So what happens when prices go up, costs go up to health insurance companies? Health insurance premiums are 80 to 90% or greater medical expenses. So health insurance premiums go up. What happens? Well, employers pay higher health insurance premiums, their health care costs go up. They're not going to alter total compensation to workers. I'm only worth a certain amount to Carnegie Mellon University, although you're free to tell my dean I'm not getting paid enough.
So
by the
wages
way.
go down
Yes.
because
Dean Ramaya
basically
Krishna.
any
And
money that's in the
something's
system is
got-
going to pay for these
exactly.
increasing
Something
healthcare costs.
has to give. The employer is faced with higher healthcare costs. What happens? Wages fall, or they don't rise as much as they otherwise would. Workers pay more of health insurance contributions, or benefits are cut. In some cases, in the past anyhow, workers lose coverage entirely.
Thank you so much. I think it's important that everybody understands that small businesses and employers and people, patients, are footing the bill, and they are already paying these enormous costs. Thank you, Dr. Gaynor. I yield back.
Thank you. I now recognize the gentleman from Florida, Mr. Gates, for 5 minutes.
Thank you, Mr. Chairman. I want to begin by praising your leadership and thanking you for this important subcommittee. And while I know the important work of the full Judiciary Committee has been flavored a bit partisan at times, as I look at the work you've done on lowering prescription drug prices, taking on the excesses of big tech, I think that this subcommittee is poised for some major bipartisan successes, and I thank you for your efforts. Specifically, as it relates to the subject matter before us here, I am hopeful that the substance of the Creates Act will ultimately be marked up in committee, and I'm also hopeful that some of the PBM transparency issues that we've been discussed are able to be fully exposed. I also want to praise Florida's Governor, Ron DeSantis. Right now, one of the major challenges we face in Florida is the rising cost of prescription drugs creates a massive cost structure on our correction system, and there is currently a real opportunity for Florida and other states to import drugs from foreign markets and then to be able to lower costs substantially. That is allowed under current law in Florida. We are currently working toward that with President Trump, and so I would implore President Trump to look favorably on Governor DeSantis' request and that other states might be able to unlock the potential of lower drug prices. But, Mr. Chairman, as we are gathered here talking about the anti-competitive practices in medicine, it is really noteworthy to me that one of the most anti-competitive things that occurs is the heavy hand of the federal government constraining access to medical cannabis. And as we look at the types of prescription drugs that are sought to deal with opioids in particular, we continue to see evidence, substantial evidence in fact, according to the National Academy of Sciences, that cannabis is helpful in dealing with chronic pain, treatment of chemotherapy and vomiting, multiple sclerosis symptoms. And so it is my sincere hope, with all of the energy and passion among my Democrat colleagues on the Judiciary Committee, that in looking at prescription drug use, prescription drug abuse, and prescription drug cost, that we unlock the potential of medical cannabis and that we get the government out of the way so that it is not impairing the relationship between physicians and patients. I wanted to take a moment to ask Mr. Garthwaite, in this broader discussion we're having about consolidation, what role does the federal government have in spurring consolidation through excessive regulation of the health marketplace? And by that I mean, as the federal government becomes more and more involved in what qualifies for drawdowns to states and the provision of health care, does that excessive regulation and the compliance cost it drives, is that a contributing factor in your review of maybe a consolidation incentive?
I think part of what you're getting at is there is some fixed cost of dealing with regulations and compliance. I think at the state of the sort of landscape at this point, most of these firms are big enough that they're able to cover that fixed cost. And I would agree with Dr. Gaynor that a lot of this is not about sort of being driven by federal regulation. It's being driven by either attempts to seek higher prices or attempts to coordinate care.
And Dr. Gaynor, would you reflect on the role that PBMs have in the health of the prescription drug marketplace?
I wasn't asked to prepare testimony on that topic, but I am happy to reflect on it and submit a written response to your question.
Great, thank you. Those are my questions, Mr. Chairman. I'll yield back.
Thank you very much. And I now recognize the gentlelady from Florida, Ms. Demings, for 5 minutes.
Thank you so much, Mr. Chairman, and thank you to our witnesses for being here with us today as we discuss this very, very important topic. You know, I'm reminded of a quote from Dr. King, who said, "Of all of the injustices, and there are many that exist, the lack of health care is the most inhumane." And so this is a critical subject to all of our districts and our communities. My colleague, the ranking member, talked about the number of mergers that have occurred in rural areas. And I know, Dr. Gaynor, you mentioned that it's not just occurring in rural areas, but across our nation. But I do believe that in rural areas, the effects can be much more devastating because the lack of access, quality of care, access to services, all of those dynamics. And so could you just please talk about the extra harm, if you will, that mergers do or have, the effects, the negative impact that they have on rural communities?
Representative Demings, thanks for your question. Yes. Well, because folks in rural communities live much farther from other healthcare providers, hospitals, doctors, nurses, et cetera, if there are mergers in rural areas that leave them with few alternatives, their next best alternative can often be miles and miles away. And of course, for some kinds of care, it's either very difficult or impossible for people to travel, emergency care, obstetric delivery, but even if they are willing to travel, it's a long way. And so that imposes real costs on them, and that means that if there are providers in the area, they have much more ability to have prices be higher. They're under much less pressure to do better, to have better quality, provide better service, better access, better community benefits. So I think that, that those of us in America who live in rural areas are particularly vulnerable to these kinds of harms.
Could you also talk about what type of positions in terms of employees when hospital mergers occur? What type of employee or hospital worker is really the most vulnerable in that environment?
Well, it's the folks who have skills as workers that are most specific to working in a hospital. Because if their best alternative is to working in a given hospital, and now there's a merger and the next hospital over is no longer available to move to because they're now one firm, then they don't have such great alternatives. If they're workers who have very general skills, so if you're a food service worker in a hospital, you might not prefer to work somewhere else, but you could go and work at another company and be a food service worker there. So when a hospital merger happens, the hospitals can't squeeze your wages or your working conditions too much. But if you're an OR nurse, where else are you going to go? You may be able to go elsewhere, but it won't be as good a job.
And finally, Dr. Morton, would you just, again, please describe for me, what is the connection between a lack of competition and the rising cost of health care?
Lack of competition means that providers of various kinds, drugs, devices, hospitals, doctors, don't have to compete with one another for the business of patients. And competition generates both lower prices and also more innovation and more quality, more choice for all the consumers of healthcare. When we don't have competition, we have higher prices and lower quality, and that just hurts everybody, both the patients and the taxpayers.
Thank you. Mr. Chairman, I yield back.
I thank the gentlelady for yielding back. I now recognize the gentleman from North Dakota, Mr. Armstrong, for 5 minutes.
Thank you, Mr. Chairman. And I guess my first question is for Dr. Gaynor. We have, in North Dakota has been a little different since 2010. We have had an actual boom in our economy. So prior to that, we were suffering the same type of problems the rest of rural America was facing. But what we've noticed is lack of workforce shortage. We have we probably have, if not the best, one of the best rural hospitals in the country because it's brand new and it's fantastic, but we're having trouble staffing it. And so when we're talking about these consolidations in rural areas, and we've seen it, they move into yes, we have urban areas in North Dakota, and they move into the more urban areas, but are these these aren't all motivated by anti-competitive behavior. I mean, factors such as worker shortage, nurse shortage, provider shortage, resources and financing are part of this equation, aren't they?
So, as I said, there are multiple multiple motives for mergers and acquisition. I don't know that labor market issues are a primary driver. I haven't heard that. There can be incentives. These usually happen more in acquisitions than in mergers, where a smaller hospital wants to be acquired by a larger hospital that has more resources, particularly if that hospital is struggling. Then you can certainly see that. But I'm not aware of labor market issues as being a motive driving these mergers and acquisitions.
Maybe it's just unique to our geography. But part of that, we've talked about licensing and state licensing, and states are all very good at putting up their own white picket fences and ensuring that a nursing degree or a nursing license in Minnesota doesn't apply in North Dakota. And we work on those at the state level a lot, and I think a lot of different states are starting to see that the world's becoming a much smaller place. So when these consolidations happen, whether they happen make economic sense, are there any policies here, and I guess this question would kind of be for everyone, that we can do at the federal level that promotes access, whether it's urgent care centers or things in more rural areas? I know they're starting to do strep tests at pharmacies in rural areas in our district, and before we get into crossing pharmacists with doctors or nurses, but I mean, just to continue to provide some semblance of access in rural America? Question mark.
Well, yeah, I think there are a number of things. One I mentioned previously is making sure that licensing is tailored very specifically to the purpose of protecting the public and doesn't overstep those bounds, so that nurses and pharmacists, for example, are permitted to do the things that they have been trained to do and qualified to do, and that creates more access right off the board. And so I think that's a principle. Now that's state level, but the federal government can try to work with states, try and provide information and support to states in this area, and I think that can actually make an important difference.
Anybody else have anything?
I would agree. I think occupational licensing is often used as a barrier by incumbent licensed people to keep out others. And if you have a shortage of a certain medical worker, it's not like human bodies are different as between North Dakota and South Dakota and any other state. So it might be reasonable to imagine that the requirements for being a nurse or a doctor are the same across states. And if we had fewer differences, workers could move more easily.
Yes, sir.
Yeah, I also note that we're seeing private firms start to address this as well. So some of the motivation behind some of the vertical integration we're seeing in healthcare, and this committee had a nice hearing on CVS Aetna as a merger, but some of the motivation behind that is about finding new sites of care, maybe finding ways we can treat chronic conditions at retail settings, be it a CVS. Walmart is thinking about these things as well. Those will provide more access for care in places that aren't the traditional general acute care hospital or a doctor's office, which can often struggle to be a standalone business in a rural area given a lack of demand.
Thank you. And I think that's important because the economies of scale, I mean, it's not unique to the medical profession. We are seeing more and more of this happen in rural areas as we continue to move out.
Just one last thought, and this has already been addressed in part by Congress, and that's what are called site-neutral payments for Medicare. I think you're familiar with those. Payment for the same kind of service delivered by the same kind of professional can be many multiples if it's dubbed in a hospital, and that creates some distortions that may favor those things and then actually end up penalizing people in rural areas.
Thank you. I yield back my negative 15 seconds.
I thank you, and now recognize the gentlelady from Florida, Ms. Scanlon. No,
Pennsylvania.
Pennsylvania.
I didn't move, yes.
There's a lot of Florida down at that end. My apologies. Pennsylvania for 5 minutes.
Thank you. So there are a few questions that came up, or a few topics that came up more frequently when I was running last fall than about affordable health care. And in that sector, the biggest question I kept getting is, what can we do about prescription drug prices? over and over. So it's a priority for my constituents and therefore a priority for me. And in addition to being very worried about this, they're also really smart. So they fed me specific questions. So Professor Scott Morton, the question of evergreening of patents. So as I understand that is sort of tweaking patents to extend the amount of time that there's proprietary rights. Can you speak to that and how that impacts the prices of drugs?
Yes, this is a tactic whereby, let's say there's a drug that's twice a day, and the manufacturer invents a once-a-day version and patents that, or maybe even takes 50 milligram and makes a 60 milligram tablet and patents that, and then releases that new product on the market, and in some cases removes the old product that's about to be generic and therefore much less expensive. This situation could be really helped with a couple of policies. So one is generally strengthening the antitrust laws and allowing the FTC to go after behavior that it feels is anti-competitive. But another one is reforming the incentives of the PBM. The PBM should want everybody to take that generic drug because it's cheaper and not steer them to the more expensive one. And when we have perverse incentives, that latter thing can happen. In general, however, we don't want to get into the business of saying, is this innovation good or not, but rather subject it to the market test. Once a day could be a super valuable innovation. And if it has to compete head-to-head with twice a day, we'll find out. If, however, the launch of the once a day is accompanied by the pulling away of the twice a day, we don't have head-to-head competition anymore. That's a situation where it looks like the manufacturer didn't think their once a day was going to win, and that's why they took away the twice a day.
Okay, thank you for that. Mr. Cadis, in 2013, the Supreme Court held in FTC versus Actavis that pay-for-delay settlements, which occur when a branded drug company pays a potential generic competitor to delay entering the market with a lower-cost generic, likely violates the antitrust laws absent a justification. Can you comment on whether that decision is sufficient or insufficient to address the pay-for-delay settlements? And, is there something we can do about that?
Yes, thank you for the question, Representative Scanlon. So at one level, the Supreme Court decision was good because until that time, courts were taking the position that a patent holder could pay any amount of money to secure the agreement of the generic not to manufacture its drug. And because the brand makes so much more than the generic, these were very common. And so once the court said you can do this, agreements went up. Supreme Court, in principle, the rule makes sense. The problem is that it is not, the lines aren't clear, and there's been lots of litigation. I think when I said in my opening statement, there was a case that settled just last year, and it was filed back in 2006. So what you're having to happen is that the government is spending lots of resources to prove that paying your potential competitor not to compete is a problem. And we live in a world of limited resources. So as other people have talked about other things, whether it be the rebates and the PBMs or other things, the product hopping, the government can't even get to those cases because they're basically left having to prove these basic ideas that we all should agree are anti-competitive.
I know one suggestion to address this is to establish a presumption that these pay-for-delay settlements are anti-competitive. Do you think that's a good idea, or are there other legislative fixes that you would suggest?
I think that is an excellent idea. When you look at both the economic theory behind what happens in a pay-for-delay settlement, and we actually have evidence that empirical evidence that these types of agreements delay entry, then you should start with the proposition that if someone's paying a potential competitor in a settlement, we should presume it's harmful and make them come forward if it's not. Instead, we have it the reverse, which makes no sense given what we know about theory and the empirics.
Any other suggestions in that pay-for-delay arena for legislative fixes?
So I think part of this is making sure it's sort of complementary. These are incredibly enticing deals. So in one of the cases I worked on, the company paid $60 million, and managed to protect close to $1 billion. And another one, after the company paid off four generic competitors, boasted, we got 6 years and $4 billion that nobody expected. So you have to have a really strong penalty provision. If all the government can do is say, oh, you broke the law, promise us you won't do it again, that's not going to be effective, and there's going to be no reason for companies to settle. You have to be able, the government has to be able to go in and say, no, you don't get to keep the money because you earned it by breaking the law.
Thank
The
you.
time of the general ladies has expired. I now recognize the gentleman from Colorado, Mr. Neguse, for 5 minutes.
Thank you, Mr. Chair. I want to thank the panel for being here with us today and for your testimony. Also want to thank my colleague from Wisconsin for raising the important issue regarding rural areas in particular, where this is very pernicious. Certainly in my district, I represent a variety of counties, Summit County, Eagle County, mountain communities, more rural in nature, where this is a big problem and the effect is very pronounced. So Dr. Gaynor, I want to call out one particular finding, which I think is fairly intuitive, but your data certainly supports it from your written testimony here. I'll quote, one of our key findings is that hospitals that have fewer potential competitors nearby have substantially higher prices. Well, for example, monopoly hospitals' prices are on average 12% higher than hospitals with 3 or more potential competitors nearby. That's a very important fact worth repeating. And one of the recommendations you make, and Dr. Morton makes as well, that I believe is particularly compelling, is around nonprofit hospitals, which is a big part of this discussion that often gets left out. And I think part of it is because there is a misperception about the nature of nonprofit hospital entities in some cases. I am sure members of the panel serve on nonprofit boards. Dr. Gaynor, you've created the Healthcare Cost Institute. I am curious. I imagine that the CEO of the Healthcare Cost Institute does not have a private jet. Would I be right in saying that?
I'm no longer on the board, but I would be extraordinarily chagrined were that the case.
All right, they're not making tens of millions of dollars, right?
No.
Dr. Cadis, I hope I pronounced that right, Cadis?
Cadis.
Cadis, yes, sir. And you, of course, are the director of a nonprofit entity, the Washington Center for Equitable Growth. Is that right?
I actually am the director of the competition policy. The Washington Center for Equitable Growth is a much bigger organization.
Well, I trust that the director of that entity is probably not flying around on a private jet and making tens of millions of dollars either. But.
I think that's a fair assumption.
All right, and so here's my point, right? Wall Street Journal, this is relatively recent, last 2 years, as of December 30th, 2016, tax filings as of that date, prepared kind of a summary. And you have a variety of hospital executives at various large nonprofit hospital systems. Ascension in St. Louis, $17 million in annual compensation. Norwell Health, $10 million. Highmark Health, $9.8 million. Mercy Health in Wisconsin, $8 million compensation package. Variety, right? You can encourage folks who are watching to just Google, nonprofit health CEO and private jet or private chef or any variety of other compensation packages that are attached to folks who are working in those industries. And I think what we have kind of lost sight of, right, is that the charity aspect and obligation that a nonprofit hospital has, right, embedded in its purpose as an entity. The FTC in 1999, there's a report, go onto the website, I was 15 years old in 1999, this is a long time ago. There's a report titled Competitive Effects of Not-for-Profit Hospital Mergers. And I'll quote from it. It says, mergers involving not-for-profit hospitals are a legitimate focus of antitrust concerns. And yet here we sit 20 years later, and the FTC has no power to essentially engage in this important area. And so I'd like to give Dr. Gaynor and Dr. Morton perhaps an opportunity to kind of talk about this, because I think it's a pretty simple change in the law that we could make, that Congress could make, that would really open this up. Again, a lot of not-for-profit hospitals are doing incredible work, good work, but there's a case to be made for the FTC to have expanded authority in this regard. So, care to comment?
Yes, thank you, Representative. So I agree 100%. Just to be clear, the FTC does have the authority to pursue mergers under the Clayton Act, But what they do not currently have the authority to do is pursue anti-competitive conduct by nonprofits under the FTC Act. So I agree. I think that needs to be revisited and revised so that both our antitrust enforcement agencies are using all the tools in the antitrust arsenal to address the pressing issues in this sector. And let me say, again, yes, most hospitals in the U.S. are technically nonprofit, but the numbers you gave out are eloquent testimony to the fact that this is big business. Once upon a time, they were charities, but that was a long time ago. When healthcare is 1/5 of our entire economy, when UPMC is a $10 billion revenue company, the largest private employer in the state of Pennsylvania, and that's replicated over and over and over again, they're no longer charities, they are big businesses.
The time of the gentleman has expired. Thank you. I now recognize the gentlelady from Georgia, Ms. Macbeth, for 5 minutes.
Thank you, Mr. Chairman. And once again, to reiterate, as many of my colleagues have today, I just want to thank each of you for coming and sharing your testimony with us today. And I'd just like to thank you for being here, because this is something that's extremely important to me, because it has touched me personally. I'm a 2-time breast cancer survivor, and I understand what it's like to have your life completely turned upside down overnight. Having that diagnosis once was, I can tell you, just you go into a crisis mode, but to have it a second time wreaks even more havoc than it did the first time. And the stress of the financial burdens that follow are just weigh so heavily, not only on the individual that has been diagnosed, but also the entire family. Now, I had the benefit of being in a breast cancer study that allowed me to have discounted treatment as well as pharmaceuticals. So I realized that I was very fortunate in that regard. Even though I was fortunate to have very good health insurance, I worked for a major corporation, major company. I worked for Delta Airlines. I was under a really good group health insurance program. I still worried about my medical bills and my needs, and how would my family be so adversely affected by this health crisis. And so, even though I had good benefits, I could not even imagine what it would be like for a family that didn't have the ability to have the kind of health care that I had the fortune of having. Now, I want to say that my story is absolutely not unique. It's stories like this that we hear every single day from Americans across the country. And just this week, I heard from a family, a woman within my own district in Georgia, who told me that she spends $1,500 a month on diabetic supplies for her daughter who has type 1 diabetes. And that's more than her monthly mortgage. So Dr. Scott Morton and Mr. Cadis, could you speak very candidly to what should be done to bring down prescription drug prices, those costs, while also supporting innovation and research, which is so sorely needed?
I would say that in my written testimony, I describe a way that you could cap out-of-pocket prices, which is, I think, the most harmful thing that consumers and patients are experiencing now, and combine that with a ban on kickbacks by the pharmaceutical company in the form of coupons, financial aid, wraparound services, and so on. This would leave patients protected and then enable competition, because without being able to incentivize the patient, the manufacturer would have to sell its drug to the PBM, and then it would have to compete with other drugs in order to sell its drug to the PBM. So the key in restraining prices that patients pay out of pocket is to do it in a way that enables as much competition as possible, so that you keep the prices paid by the insurer low, because of course we all pay premiums, so that's the other way in which this is very expensive, not just out-of-pocket costs. So the two sides need to go together.
Thank you.
Thank you for the question. So I'm going to come at this from my experience as an antitrust lawyer, and what can we do, what's wrong with this marketplace in terms of anti-competitive conduct, right? And the issue here is a branded company makes a pile of money, and they are insulated from price competition generally until there's a generic. And that one, just having a generic totally changes, prices go down, they lose most of their sales. And so there's a real incentive to do anything possible to delay that date. And so that can be you pay your competitor not to compete, which we were talking about. It can be the product hopping stuff, conduct that Fiona was talking about. And right now, the antitrust laws have been so weakened that we can't stop this conduct. But the good news is, if we strengthen those laws or pass things like the Creates Act, it will make it harder to prevent competition, but it really shouldn't have any impact on innovation, because these are all types of strategies that are just about about obtaining anti-competitive rents. It's not about innovation. So this is injecting competition into the marketplace gets you the benefit of lower costs without without undermining incentives to innovate.
Thank you so much. I yield back the balance of my time.
I thank the gentleman, and now recognize myself for 5 minutes. Again, thank you to the witnesses. I want to begin broadly talking about competition. I'm very concerned about the rising tide of economic concentration throughout our economy and the really crippling effects on economic opportunity, innovation, and equality. Earlier this week, Professor John Kwaka of Northeastern University testified before the Senate Antitrust Subcommittee. He said concentration has been steadily rising and competition declining in a great many sectors of the economy, raising legitimate concerns about increasing market power in large swaths of the U.S. economy. Robert Reich, the former Secretary of Labor in the Clinton administration, similarly noted, and I quote, "America has a monopoly problem. America used to have antitrust laws that stopped corporations from monopolizing markets and often broke up the biggest culprits, but antitrust has faded. The result has been hidden upward redistributions of money and power from the majority of the Americans to corporate executives of and major investors in huge concentrations of economic power," end quote. So, Dr. Scott Moore, I'd like to start with you. In your written testimony, you identified a lack of competition as a reason why U.S. healthcare costs are rising so fast, and that antitrust enforcement has been weakened in the United States for a variety of reasons. What are, in your view, the primary reasons that enforcement has so weakened?
The primary long-run reason is that we were all influenced by the Chicago School in the 70s that believed things like monopolies are inherently transitory and oligopolies will price at marginal cost and courts make bad decisions. And these kinds of presumptions that we now know after 40 years of studying the economics literature are false. They weren't true to begin with, and we now are much more sure of that. In addition, we also see the evidence in front of us, which is rising markups, lower labor share, higher profit share, all the different evidence that you pointed to. So it's clear that the pendulum has swung past the ideal point by quite a bit, and we need to turn it around. But because courts now interpret the antitrust laws in this way, I think it's up to Congress to instruct the courts that actually Congress would like it done a different way.
Thank you, Doctor. And that leads to my next question to Mr. Cadis, who just in the end of your testimony just a moment, you talked about the weakening of the antitrust enforcement and wondering whether you have suggestions of the kind of legislation we should be contemplating that would really strengthen antitrust enforcement.
Thank you, Chairman, for the question. Yes, one of the sort of subtleties about why antitrust is weak is that we've made it just hard and expensive to prove an antitrust case, whether it be a government or private plaintiff. So we know how to fix that. The way to fix that is you create presumptions where we're confident that the conduct is likely to be anti-competitive. And there's lots of economic evidence about certain types of mergers that we can be comfortable are likely to be anti-competitive, certain types of conduct. I mean, in many ways, the Creates Act it's not an antitrust law, but it sort of takes that idea that where you have conduct that you are confident is not justified, you need to make it easy to prove. And so that's what I would say, more presumptions to address based on the empirical evidence of where we know things are likely to be problematic.
Thank you. And Dr. Gaynor, do we have, or do the antitrust agencies have enough resources to do the work that we expect them to do? And if not, what would you recommend in terms of additional resources or other things you should recommend, that you would recommend that would help improve merger and anti-monopoly enforcement?
Chairman Cicilline, thanks for your question. First, I just want to say I agree with my colleagues, Dr. Scorp-Morton and Mr. Cadis, and I think those are important issues to be addressed, but you turn to the other side, rightly so. Suppose we do the kinds of things that my colleagues have suggested, which I agree with 100%. The agencies will need more resources to do more. It's that simple. Over the past 7 to 10 years or so, merger filings have risen by about 57%, and appropriations in inflation-adjusted terms have fallen by 12%. The number of staff is either constant and declining in the Bureau of Competition, Bureau of Economics, at the Federal Trade Commission. As a consequence, what happens is the agencies are faced with an extraordinarily difficult choice between how much to do based on what's coming in over the transom, which is coming out of a power hose, given the rise in merger activity, and trying to stay abreast of new developments. They desperately need the resources, additional resources, to do that.
And I'm just going to squeeze in one last question. Over the past several years, Sarah Cliff, a reporter for Vox, has documented the outrageous practice of surprise billing in hospitals. And she's reported the price of ordinary drugs that could be cheaply purchased at a local pharmacy, such as generic eye drops or pregnancy tests, often cost hundreds of dollars. And additionally, patients often painstakingly choose to receive care in hospitals that are covered by their insurance, only to find out that an emergency room doctor who treated them was not covered by their insurance. As a result, they receive surprise bills that can cost tens of thousands of dollars. And just wondering, starting with you, Dr. Gaynor, is obviously this is further evidence that our current system is fundamentally broken, and I'd also like Dr. Scott-Morton to reflect on that.
Right, 100%. I mean, this is unacceptable and can't be allowed to continue. And moreover, this sort of thing undermines markets. People think they're making a responsible choice by going to an in-network hospital, and then they get socked with this astronomical bill they had no way to prevent. Why should they shop? Why should they buy insurance policies that ask them to do that? So it's going to undermine the market. And there are some relatively simple remedies for that. Fiona Scott-Morton and Zach Cooper have proposed one, so I'll yield to her because she's the one who can talk about it.
And I am thanking my ranking member for indulgence of 1 minute. I don't want to abuse my power in my first meeting, but if it's okay, Dr.
Yes,
Scott-Morton.
so this is a really bad problem, and it just comes from the fact that we have quite a regulated system, and sometimes there's a loophole, and then financial players can go in there and say, look, there's a business model. I insert these doctors into a hospital, pull them out of network, and double the charges or triple them. So what our proposed solution is that hospitals need to sell the bundle. They need to sell all the care you get in the emergency department. The hospital can go out and organize the doctors. They could employ them, they could contract with a group. But then at least when you arrive at the in-network hospital, everything you're getting in the ED is in-network.
Terrific. Thank you again to our witnesses. This concludes today's hearing. Without objection, all members will have 5 legislative days to submit additional written questions for the witnesses or additional materials for the record. The hearing is adjourned.